Well, thank you very much, Johnny. And first, let me say, unlike these two wonderful gentlemen, I have no disclosures pertinent to this lecture. And the question, I'm going to be addressing three questions. First of all, is an IPMN a precursor lesion to an adenocarcinoma? Is it part of a generalized pancreatic genetic field defect? Or is it an innocent bystander? And the answer is yes. And so with that, I'd like to conclude my remarks. As you know, IPMNs are characterized by papillary growths within the pancreatic ductal system with thick mucin secretion. Depending on the degree and type of mutations, these lesions are at risk for following the dysplasia carcinoma sequence, and they may undergo malignant transformation. I've been a radiologist 40 years, 3 months, and 4 days, and I'd like to tell you my experience with IPMNs. What's an IPMN? Never heard of it. In the 1980s, I'd probably see 1 to 2 cases annually, and I think they were called ductal mucinous pancreatic neoplasms. In the early 1990s, probably 1 case a month. In the late 1990s, maybe 1 to 2 cases weekly, and in those days they were called IPMTs. And nowadays, I see 2 to 5 patients with incidental and follow-up cases on the days I'm doing MR. It's funny, I don't see them on the days I'm doing fluoroscopy. This is the first case I have from early in the 1980s with this huge pancreatic duct, and this patient went to surgery, and the pancreatic duct was big, and this was the ERCP image, this mucin just coming out of the papilla vater. I was involved with the Incidental Finding Committee both in 2010 and 2017, and may I strongly suggest that you follow the American College of Radiology guidelines, because if you don't, President Trump will launch a cruise missile at your institution. So you must follow the American College of Radiology guidelines. Okay, so what was our knowledge back in 2010? Boy, it was very simple. Follow these patients for every 6 months for 2 years, and it was stable. You're home free. How naive we were back then. Now, Alec Megabau and the rest of the Incidental OMA Committee, there are now 5 different protocols or algorithms for that, and they're all available for free online at the American College of Radiology website. And I'll go through the IPMN algorithm at the end of the presentation. Now, why has there been this change? First of all, there have been thousands of articles about these incidental pancreatic lesions, especially IPMNs. IPMNs are increasingly recognized as a field defect because of their propensity for multifocality, which places the entire pancreas at risk, and so this is a field defect. Synchronous IPMNs occur in up to 83% of patients, and the risk of developing a significant metachronous lesion is 8%. So here's a patient who actually has a double whammy. This is a woman who has a mucinous cystic neoplasm and an IPMN in the tail, and also one in the region of the pancreatic neck. Each lesion that we see should be individually risk stratified. The rate of a concurrent ductal adenocarcinoma is about 4%, and for metachronous development of a ductal adenocarcinoma is up to 11%. So you can have a pancreatic ductal adenocarcinoma starting de novo, and the patients usually have KRAS mutations. And of all malignancies, I think pancreatic neoplasms are the ones most associated with identified pancreatic or genetic mutations, and that's why actually we have a large pancreatic surgery service at our hospital, and all patients who undergo endoscopic ultrasound and with aspiration will undergo genetic analysis. Or you can have an IPMN that starts, or the IPMN can degenerate into a carcinoma, or you can have an IPMN, but because of the field defect, you have an adenocarcinoma developing elsewhere. Now, it's important to differentiate pancreatic ductal adenocarcinoma occurring concomitantly with IPMN from carcinoma arising within an IPMN for risk stratification studies. Concomitant ductal adenocarcinoma is reflective of the risk of the entire pancreas, and malignant degeneration of an existing IPMN defines the malignancy risk of branch duct IPMNs. So you look at your worst lesion, and if the worst lesion is going to be a cancer, the entire gland has to be surveilled as if it has an adenocarcinoma. So what is the classification of IPMNs? First of all, you can have a branch duct IPMN, or you can have diffuse dilatation, or there might be segmental dilatation of the pancreatic duct, or you can have dilatation of the main pancreatic duct and side branch. This is the least ominous or least worrisome. This type of duct is more worrisome. The incidence of malignancy in IPMNs, if you have a main duct IPMN, there's a lifetime risk of up to 61%. And if you have a side branch IPMN, there's a lifetime risk of developing cancer in approximately 17% of patients. IPMNs are also classified by their cytology. There's gastric mucosa, intestinal, oncocytic, and pancreaticobiliary. Branch duct IPMNs are most commonly associated with the gastric subtype, and this has the least likelihood of tumor invasion and tumor recurrence. Main duct IPMNs most commonly have intestinal type epithelium, which has a high likelihood of progressing to carcinoma. The oncocytic type tend to have a very indolent biology, and the pancreaticobiliary epithelium is associated with the highest rate of tumor invasion and transformation into carcinoma. Thank goodness for endoscopic ultrasound, because that's always, when we see something that's indeterminate or suspicious, we recommend endoscopic ultrasound. And as Jay was describing very nicely, you look at the CEA, and if it's less than 192, that makes you feel that it is not a mucinous cystic neoplasm. However, a CEA can be low in up to 30% of patients with mucinous cystic neoplasms. Since IPMNs connect with the pancreatic duct, the amylase is usually sky high. These patients have KRAS and GNAS mutations quite commonly, and also they have stain positive for these monoclonal antibodies. Quickly reviewing who gets an IPMN. As we know, grandma tends to get a serous cystadenoma, mother tends to get a mucinous cystic tumor, and daughter gets the SPID, or a solid pseudopapillary tumor, used to be called a SPEN. And who gets IPMNs? It's usually grandpa and, to a lesser degree, grandma. Let's first talk about side branch IPMNs, and that one doesn't look too ominous. And here's one. It looks like a pair, and here on CT, you can see the communication with the duct quite nicely. Here's another one. This patient has multiple side branch IPMNs. This one has a little bit of a nodule, so that's a little bit concerning. But the main pancreatic duct is normal in caliber. Here's another patient who has one in the tail, but there's not significant dilatation of the pancreatic duct, so that's somewhat reassuring. Here's another one who has a cluster of these grapes in the pancreatic tail and in the region of the neck. Let's look at some main duct IPMNs, and this is very impressive. This is also very impressive. It's hugely dilated in the region of the pancreatic tail, and both of these have, these patients certainly will need endoscopic ultrasound. Here's a patient lent to me by Alec Megabo, where you can see the mucin coming out of the papilla of Otter, the major dilatation of the pancreatic duct, and on endoscopic ultrasound you could see the small nodule. Now I'd like to show you a few examples of mixed main duct and side branch IPMNs. And this patient has a huge main pancreatic duct and a number of large side branch IPMNs as well. Here's another patient. I'm seeing this more commonly now. Patients who have main duct IPMNs may fistulize to the duodenum. We see it here. And here's another patient where it's fistulizing to the duodenum. This patient also has biliary obstruction. And here's a case on MR where this one was fistulizing to the region of the splenic flexure of the colon. Now, what are some worrisome features? And this is from, there was an article published recently in JAMA, and they considered 7.2 millimeters as the optimum cutoff for a prognostic factor for main duct and mixed duct IPMN. That is to say, if it's greater than 7.2 millimeters, there is a much significant increased risk of there being a neoplasm. This is from the ACR guidelines published in 2017. So what are some worrisome features? If the cyst is 3 centimeters or greater, if there is thickening and enhancing of the cyst wall, if there's a non-enhancing mural nodule, or if the main pancreatic duct is greater than 7 millimeters, and that JAMA article says it's 7.2 millimeters. What are high-risk stigmata? If you see obstructive jaundice with a cyst in the region of the head of the pancreas, an enhancing solid component within the cyst, or as in this patient, main duct caliber equal to or greater than 10 millimeters in the absence of obstruction. All right, so here's some more worrisome features. We see this duct is greater than 1 centimeter in diameter, and this patient had this nodule. Now, this one did not enhance, so we don't know whether it's tumor or mucin, but this is also concerning. Here's another patient. This cyst is quite large. It's multiseptated, and it also has a filling defect. Here's another patient on CT. The duct is greater than 1 centimeter, and it also has a mural nodule. And here's the patient I showed you before with huge dilatation of the region of the pancreatic tail, and it tapered a little bit towards the region of the pancreatic head. And here's another patient, hugely dilated. It almost looks like chronic pancreatitis, but this patient had both a main branch and side branch IPMN. The same features that we assess are the same features that the gastroenterologists assess when they look at these patients. They look to see if there's a nodule, they look if there's mural septation, and also they put on color Doppler to see if there's increased flow within that nodule. Now, what is about comparing the diagnostic performance of endoscopic ultrasound, CT, and MR? And actually in this study, for finding solid enhancing component mural nodules, or dilatation of the pancreatic duct, thickening of the septa walls, and abrupt caliber in the change of the diameter of the main pancreatic duct, they found in this series that endoscopic ultrasound, CT, and MR were comparable. I think endoscopic ultrasound is the best, followed by MR, and then I'd rank CT as third. Diffusion-weighted imaging, is it helpful? Well, we do diffusion-weighted, it doesn't take much time. We add this to all our pancreatic protocols, even the follow-up. There was a study published earlier this year in abdominal radiology, and they found that conventional mean ADC was not significantly different in benign and malignant IPMNs. They found that to make it useful, you have to do histogram metrics, and they found that ADC entropy was the best performing feature for differentiating benign and malignant IPMNs. So we certainly will add diffusion-weighted imaging, and I would agree with Jay. Sometimes you can see a mural nodule better that way, and also if the lesion is large enough and the SUV is high enough, that is helpful, but I just think conventional looking at an ADC is not 100% in differentiating benign and malignant IPMNs. Oh wait, what about PET-CT or PET-MR? Here was a study in which they found a significant overlap between benign and malignant IPMNs. So we don't typically use PET-CT to help differentiate them. We're now looking at elastography, and I'd be interested in asking Johnny, are you doing elastography in your place, and is that useful?
No, I don't. I experience with the mirror, it's not here.
Okay.
And there's much overlap between serious and
Okay. And so Johnny was saying that with elastography, there's too much of an overlap between benign and malignant IPMNs. What about follow-up? Okay, I guess you can watch things grow like this. Or this patient refused surgery, and you can see the transformation from this rather innocuous-looking lesion into this full-blown invasive adenocarcinoma. Here's now the patient that we followed, and the cyst was 4.0 centimeters in 2009, and then it developed a mural nodule, and here was a mural nodule, so this became resected. What about follow-up of patients with resected IPMNs? Patients with a resected invasive cancer arising from an IPMN should have ductal adenocarcinoma follow-up given the same risk of systemic and local recurrence. So these patients, if they have an IPMN and with a malignancy and a ductal adenocarcinoma, you have to follow them up as any patient with a pancreatic adenocarcinoma. Jay was referring to this article from Hopkins. In patients who undergo resections for benign IPMNs, the risk of developing an invasive cancer was 38% to 10 years, so that's a very concerning finding. Family history of pancreatic cancer, these patients with benign IPMNs tend to have a higher incidence of developing recurrence, a concurrent adenocarcinoma, and extrapancreatic malignancies. And so there are many different guidelines. Here's from the International Association of Pancreatology. This is from the AGA, and Jay discussed that. And now I'd like to take you through the one from the American College of Radiology. And this is for incidental lesions 1.5 to 2.5 centimeters. And there is main duct communication, so we know this is an IPMN. So for these patients, you follow them up to 10 years. And again, this is, and if they're benign and they don't move, you just stop searching these patients or evaluating them at 10 years. If they're between 2.0 and 2.5 centimeters, you follow them every 6 months for 4 years, then 1 year for 2 years, and then every 2 years for 3 times. And if it's stable, you stop after 10 years. If there's interval growth, you do endoscopic ultrasound. Or you may elect, if there's some disturbing features, you can do endoscopic ultrasound with fine needle aspiration immediately. There are some patients who have these very ominous-looking IPMNs, and these are high-risk surgical candidates, or some patients don't even want to go to surgery. So there are ways at our institution, our gastroenterologists will aspirate the cyst, and then they can inject either alcohol or anti-tumor agents into the cyst, and the total injection volume should not exceed the aspirated volume to avoid leakage and parenchymal injury. Also, it's important to realize that 10 to 40% of patients with IPMNs will have an extrapancreatic malignancy, either colorectal, gastric, bile duct, and renal cancers. So when you follow up these patients, you have to look at these other organs as well. Which brings up the point, when we follow patients with a pancreatic cyst, we have a limited pancreatic cyst protocol, but do keep in mind that these patients may get malignancies elsewhere. So I'd like to conclude by saying that IPMN is an absolutely fascinating lesion. It's not as benign as we once thought 7 years ago, and there's still a lot of work to be done in terms of evaluation and treatment of these lesions. And I thank you for your attention.